Kunil sir, please start.
Yes, good evening, everyone. The Greater Pune Chapter has organized a webinar on SFM Super Hit series of Young Guns. Today's we'll have presentations from six young guns: Dr. Devashri Salunkhe, Dr. Vivek Mane, Dr. Pooja Verma, Dr. Sumit Dulchete, Dr. Sonia Patankar, and Dr. Rahul Kataria. And I'm sure they are going to exceed the very high level set up by the previous young guns. So over to the young guns.
Varun, please take over.
Good evening, sir. Good evening, everyone. May I request Dr. Sabnis sir to talk about today's webinar? Our President of the Society of Fetal Medicine Greater Pune Chapter, Dr. Sabnis sir. Over to you, sir.
Yeah, join.
Dr. Sabnis has not joined yet, Dr.
He's joined, sir?
No.
All right, we can proceed with the webinar. Don't worry. We will ask him to give closing remarks.
Okay, sir.
Please call the presenter, first presenter.
Okay, so may I request the first presenter, Dr. Rahul Kataria, to share his screen?
Thanks, Varun.
Yeah, Rahul, please share your screen.
Yes.
So Dr. Rahul Kataria is a renowned radiologist working in Pimpri-Chinchwad area. The name of his clinic is Vision Diagnostic. He's a wonderful radiologist, and he'll be talking about his fantastic experience that he had about a case which we will discuss now. So over to you, Rahul.
Thanks, Varun. May I audible?
Yes, you are. And your screen is also visible.
Hello, everyone. Good evening, everyone. Myself, Dr. Rahul Kataria, consultant radiologist and director at Vision Diagnostics, Pimpri-Chinchwad, Pune. I am sharing a case, different case, parents trumping genetics. A 23 years primary gravid lady with 20 weeks amenorrhea came to me for a second opinion of diagnosis of clubfoot. She was married since 2 years, non-consanguineous marriage, no significant family or past history. Unfortunately, her dating scan and first trimester screening is not done. After the scan, I found right side rocker bottom foot. You can see that in image. The plantar surface is convex and upward turned toes. You can compare it with left side and right side. Right side rocker bottom foot, left side normal foot. You can see upward turned toes and plantar surface is convex. Fortunately, we got a good pocket of liquor. You can see tibia fibula, this ankle, curved foot. Plantar surface appears convex. In next slide, next scene, you can see turn toes. It is axial view of foot. After that, dictum is when you find one abnormality, then search for others. I could get an increased nuchal fold thickness, 7.8 mm. At that gestational age, less than 6 mm could be a normal. Then I found a normal brain study. You can see CSP, cerebellum, ventricles, corpus callosum clearly. And they were normal. Then according to ISWAP 20 plan guidelines, we can see spine, kidneys, hands, heart, they were normal. Then there were two findings, rocker bottom foot and increased nuchal fold thickness. What is rocker bottom foot? In rocker bottom foot, you can see this image, plantar convexity in lateral foot image, plantar convexity and upward turn toes. It is due to contractures of extensor tendons. We can say Persian slipper appearance. Like in this image, the tip of the shoe is upwardly turned. This image, club foot, you can see upward turned toes like Persian slipper appearance. This is rocker bottom foot. In view of increased nuchal fold thickness, unilateral rocker bottom foot, and couple was anxious. By thinking couple's anxiety about neurodevelopment and mental status, we advised them invasive testing, amniocentesis. And for that, QFPCR, microarray, and whole exome sequencing advised. Couple has done amniocentesis. We can see fish report. There is no evidence of any aneuploidy at 13, 18, 21 or on sex chromosome. Then in whole exome sequencing, we got a variant heterozygous for TNNI2 gene. It was for distal type 2 and type 1 arthrogryposis. It is a TNNI2 gene located on chromosome 11. It is a heterozygous nonsense variant in exon 8 of TNNI2 gene. It has autosomal dominant inheritance. It is classified as likely pathogenic according to ACMG guidelines. It is responsible for distal arthrogryposis. We will see distal arthrogryposis. That gene is responsible for distal arthrogryposis. Distal arthrogryposis is non-progressive disease. It is disorder of primary limb deformation without involvement of nervous or muscular system. Mainly, it has two types, type 1 and type 2. Type 1 distal arthrogryposis characterized by clenched fist, overlapping fingers, camptodactyly, positional foot deformities. You can see that in image, clenched fist is there, overlapping fingers are there, camptodactyly turned fingers, positional foot deformities. Then type 2. Type 2 is characterized by type 1 findings plus prominent nasolabial folds like these in images, down slanting palpebral fissures, and small mouth. These are two types of distal arthrogryposis. After this genetic counseling was done, risk of arthrogryposis is explained to parents, but couple sought second opinions from multiple fetal medicine specialists. Most of them advised discontinuation of pregnancy, but the couple wanted to continue the pregnancy as there is no increased risk for neurodevelopmental delay and mental abnormality. Anxious couple consulted many specialists and finally they continued the pregnancy. After that, full-term normal delivery was there. A beautiful female baby is born. You can see that in image. Baby was having isolated right side rocker bottom foot. Other foot was normal. Other joints and other systems are normal. Can compare it in both images from front view and lateral view. Comparison, left side foot was normal. Right side foot showing plantar convexity and upward turn toes. After that, baby undergone orthopedic intervention. You can see these nails and plaster cast was also there. It was for few months. The couple consulted two orthopedic specialists and they suggested the repair. You can see result. After 16 months, lady came for another consultation, abdominal sonography, and she brought her baby. You can see photograph of foot. It was absolutely normal. Baby was walking fine on her toes. Fortunately, it was corrected. My take-home message for this case is phenotype is equally important as genotype because phenotype governs genotype. We should guide patients in taking proper decisions. However, final call rests on the couple. We are not the ones to take decision. We are naturally supporting their decisions, and it was a fruitful. All is well that ends well. Thanks. Thank you for the chance. Thanks, our mentor, Emeritus Professor, Dr. Ashok Khurana sir, my mentor, Sabnit sir, Varun, Nitin, Yogesh sir, Mohit sir, and uh, Alok sir. Thank you.
Thanks a lot. Sorry, Varun, I was not able to join due to some technical issues. Extremely sorry. I apologize for that. And after that excellent talk of Rahul, I think let's begin. I welcome you all for this yet another fantastic idea, the Young Guns webinar. True to the phrase, we have today a host of city's brightest young guns presenting a plethora of cases. Uh, Not only are the cases diagnosed properly, but they have been worked up beautifully as well, including genetic testing and rest of the things. There are many cases, and we have together, we got together some great minds speaking about a variety of cases which are covering the entire spectrum of the fetal medicine. I'm sure all of you, after listening to them, will agree that these young guns will definitely give established fetal medicine specialists a run for their money. The whole idea of this series is to give these young people a chance to showcase their work on a broader platform. And I'm happy to know that many and many more are coming forward with their cases and their presentation. Polishing their presentation is especially important. This fantastic idea and taken forward by Alok sir and our own Varun Thakur has definitely paying rich dividends. And obviously, the man behind all is the master mentor, Dr. Ashok Khurana sir, without whose blessings and guidance this would not have taken place. My special thanks to Khurana sir and Alok sir for giving us this opportunity. Greater Pune chapter is a vibrant chapter, and with the help of Varun and other our young team, we have planned a lot of activities this year. We have had more than 3 outreach programs in prominent medical colleges. We have lined up yet another outreach program in a medical college at Karad, a small place from away from Pune. And we are looking forward to a big 2-day conference in the month of October, where we are fortunate to have great speakers like Adi sir and Balu Vaidyanathan sir giving their inputs to us. So now, all in all, we are looking forward to a great year at Greater SFM Pune. And I again welcome you all, and let's have a big learning bonanza today. Thanks a lot. Over to you, Varun, or over to the next speaker.
Yeah, thank you, sir. So we've already now reached 300 participants.
Fantastic.
After that wonderful talk from Rahul, may I request Dr. Devashri Salunke to please share her screen?
Yes. So is my screen and pointer visible?
Yes, Devashri. So Devashri Salunke is a radiologist. She's done her post-graduation from Manipal Hospital, Kharadi, and she's currently working in her own clinic in Hadapsar. Over to you, Devashri.
Good evening, everyone. First of all, I would like to thank SFM, Alok sir and Varun sir for giving me this opportunity to present here today and also for mentoring and guiding us. And a big thank you to Nitin sir for always guiding and supporting me. So today I will be taking you through an interesting case with some disparate findings, hence my title, Too Many Tissues, One Wrong Address. So, a 32-year-old pregnant lady came for an NT scan. She had a non-consanguineous marriage, a previous normal delivery, 8-year-old daughter who's doing well. So, our first finding was a thickened NT of 3.2 mm, which is more than 95th centile. And as we can see here, the nasal bone was present. The palate and the mandible are not clearly visualized, and as we can see here, a suspicious soft tissue mass was noted at the lower jaw region. In this cine, we can see a solid cystic lesion which is arising from the oral cavity and the lower jaw region. The lesion shows cystic spaces and calcifications within, and the mandible is not clearly visualized. The mandible appears abnormal, whereas the alveolar arch of the maxilla appears normal, and there was no intracranial extension of the mass. In this cine, we can see the vascularity is seen within the lesion. Hence, this appears to be an oropharyngeal teratoma, also known as an epignathes. These are the 4D rendered images showing us the teratoma. So, an epignathes or an oropharyngeal teratoma is an extremely rare congenital germ cell tumor which arises from the palate or the pharyngeal region. The incidence is approximately 1 in 35,000 to 2 lakh live births with a female predominance. The common sites are the hard palate, soft palate, nasopharynx, oropharynx, and the skull bone. In neonates, it can cause respiratory distress, airway obstruction, and feeding difficulties. On detailed evaluation of the brain, we found that the cerebral peduncle appears elongated with an open isthmus and the lambda sign was seen. The aqueduct also appears dilated. So this appears to be an evolving Joubert's syndrome. In this schematic diagram, we see a closed isthmus between the mesencephalon and the cerebellar vermis, which separates the aqueduct and the fourth ventricle, creating an omega sign, which is seen in the normal fetal brain, as compared with an open isthmus in which the aqueduct and the fourth ventricle are seen in continuation without any separation, forming a lambda sign in case of Joubert's syndrome. So this is a paper by Dr. Risikupu, and the schematic diagram is also from her paper. Now the lambda sign in her paper almost matches with the lambda sign in our patient. On further examination, we found other anomalies. As we can see here, the heart is displaced in the right hemithorax. The cardiac apex is seen towards the left side. The inlets are normal and the heart is normal. The stomach and part of the liver are seen herniating in the left thoracic cavity. Hence, this is a congenital diaphragmatic hernia on the left side. The couple was counseled in view of multiple findings, but they opted for termination. And this is the abortus specimen showing us the teratoma arising from the oral cavity. And we had another finding of low set ears. So this is the autopsy report in which the fetus showed significant craniofacial and limb dysmorphic features. There was an oropharyngeal teratoma protruding from the mouth. Left diaphragmatic hernia was noted, causing herniation of the left lobe of the liver in the left hemithorax, causing some anatomical distortion in the thoracic and the abdominal organs. But on autopsy, since a significant autolysis of the brain had taken place, a detailed anatomical assessment was not possible, and we could not confirm our findings of Joubert's syndrome. The histopathology report was consistent with a teratoma, and the microarray 315K turned out to be normal. This is the whole exome sequencing report, which showed us a heterozygous variant of uncertain significance. Now, while most literature documents cases found during the standard second trimester anomaly scan, detection during the first trimester is exceptionally uncommon. Hence, our case is a very rare and an unusual one involving three systems which we have been able to diagnose during the NT scan. And these are a few papers of the epignathes in the first trimester. So my take-home message would be that the NT scan is more than just a screening test. It is an early window into the fetal health. Early detection might not provide us with all the answers, but it will definitely guide us about the next crucial steps. If we find a major abnormality, we should carefully look out for other associated anomalies as well. Hence, a thorough and a detailed evaluation is necessary beyond just the NT and the NB. And you have a great opportunity to witness Dr. Rishi Kapoor in person at the Fetal Med Conference in Delhi NCR from 21st to 23rd August. So looking forward to an active participation. Thank you for a very patient listening.
That was wonderful, Devashri.
Thank
Indeed,
you.
an amazing case, beautifully worked up. You have done all the histopath, genetic workup, and everything for that patient. Really amazing.
Thank you.
Yeah, so now may I request the next speaker to please share the screen. Dr. Pooja, are you there? So Dr. Pooja Verma is an obstetrician and gynecologist. She has done her training in fetal medicine at Umarji Mother and Child Care under Dr. Chinmay Umarji sir. And today she'll be presenting on Beyond the Measuring Tapes, a tale of a life saved. Over to you, Dr. Pooja.
Thank you so much, sir. Good evening, everyone. I would want to extend my gratitude to SFM for giving me this opportunity to present the case. I'm Dr. Pooja Verma. I'm an obstetrician and gynecologist, and I've pursued my fellowship in fetal medicine under the guidance of Dr. Chinmay Umarji, and I'm currently practicing at Umarji Mother and Child Care. So without further ado, I would want to present my case now. So my case is a 32 years old woman who presented at 22.4 weeks of gestation in the year 2021. She was referred in the view of skeletal dysplasia, and when she approached us, she had already made her mind that she would want to undergo medical termination of pregnancy. But this was the time when the amendment in the MTP Act were not done. So we evaluated the patient thoroughly. We drew a 3-generation pedigree for this patient, and nothing striking came up. So we decided to scan the fetus. As you can see here, the scan showed fetal growth below first centile. All the long bones were measuring below third standard deviation. There was increased uterine artery PI, but the flow in the umbilical artery was normal. The femur length to foot ratio was 0.74, which was concerning. The thoracic to abdominal circumference was 0.97. Femur length to abdominal circumference was 0.17, which was again normal. We reconfirmed our finding using a fetal skeletal survey tool available on perinatology, and upon mentioning the measurements of the fetus, it also suggested the likelihood of skeletal dysplasia. These are the images of the fetus. And as we can see here, that as the long bones, although the long bones appear short, but the mineralization seemed okay. There is no angulation, there is no bowing, there is no fracture seen. This is the mid-sagittal view of the fetal face, showing no glabular bossing, no midface hypoplasia, no retrognathia. A coronal view of the lips and mouth showed no clefting. And for the fetal skull, it appeared normal in shape. This is a 3D picture of the fetus, which appeared normal again. And the systemic examination of the fetus. We looked for the ribs, scapulae, and the clavicle, and it all appeared okay. So then comes the question, when to suspect skeletal dysplasia? So the fundamental knowledge of skeletal anatomy, embryology, and molecular pathways are essential for the interpretation of prenatal imaging and genetic findings. All the fetuses with long bone measuring below 2 standard deviation before 24 weeks of gestation should be evaluated by an imaging specialist who is ready to offer genetic counseling for the same. This suspicion further increases when the long bone measurements are below 3 standard deviation, supplemented by a head circumference above 75th centile, as usually seen in heretophoric dysplasia. So how to evaluate a fetus at risk of having skeletal dysplasia? The following fetal ultrasound measurement should be visualized and plotted against standard values. All long bone measurements should be taken, and apart from that, we should comment on the appearance of the long bones, such as metaphyseal flaring, fractures, mineralization, bowing, and angulation. Fetal cranium should be looked for its shape, such as craniosynostosis. Facial bone anomalies should be looked for midface hypoplasia, retrognathia, glabular bossing, and clefting. Vertebral anomalies should be documented, such as the presence of or absence of it, the shape of it, whether it is wedge-shaped or bullet-shaped. Ribs should be noticed. Thoracic circumference to abdominal circumference ratio is of utmost importance, as if it is below 0.61, it shows resultant pulmonary hypoplasia, which is a marker of lethality. An elaborate fetal heart and genitourinary system assessment should be done. We should look for polydactyly, brachydactyly, CTEVs. Thus, the distal hands and feet should be looked for. Another ratio I would want to point here is the femur length to abdominal circumference ratio, which, if below 6.16, is also known to be associated with poor prognosis. But in our case, the two ratios were normal. It was 0.97 to 0.17 respectively. So this is the algorithm that we usually use at Umerji Mother and Child Care for evaluating the fetus at risk of skeletal dysplasia. So apart from the measurement part of it, always do comment on the appearance of it. Like for very peculiar cases, we might see a telephone receiver shaped femur, which is usually seen in heretophoric dysplasia, a cloverleaf skull, which is seen in heretophoric dysplasia type 2, multiple fractures, and hypomineralized skull, which is usually seen in osteogenesis imperfecta. So when the findings are this peculiar, this might advise us to look for the targeted gene mutations. So while evaluating a fetus for skeletal dysplasia, two key points should be kept in mind. One, whether there is a skeletal dysplasia. Second, whether there is any associated anomaly that might suggest a limited prognosis, a life-limiting prognosis. As for lethality, we all know that the resultant pulmonary hypoplasia is responsible for lethality in most of the cases of skeletal dysplasia. One should keep in mind that the accuracy of prenatal diagnosis of skeletal dysplasia using routine ultrasound approaches nearly 40%. So we took the geneticist opinion. Evaluation by the geneticist is of utmost importance. As we know, that many skeletal dysplasias are de novo autosomal dominant conditions, making recurrence in the future pregnancies estimated to be around 1 to 2%. Parental genetic testing is important to draw risk of recurrence while counseling such patients, which can be achieved via trio-sequencing. Supposedly, there are parents with a known heterozygous variant of one or more disorder, which could be lethal if the fetus is found to be compound heterozygous or homozygous. So there are hundreds of genes implicated in the skeletal dysplasia, and the new monogenic variant keeps on coming up. So conventional karyotype and microarray have limited ability to establish molecular diagnosis. WS and genomic sequencing offer a high yield over microarray. We did amniocentesis for this patient and subjected the sample for the following test, and all came out to be normal. Torch PCR was normal, QF-PCR, CMA750K, and FGFR3 gene mutation analysis was again normal. So, with the fading possibility of skeletal dysplasia, we continued our care in the form of serial growth monitoring and Doppler assessment as per Delphi consensus. And following are the graphical graphical representation of the fetal growth. And as you can see here, the interval growth was maintained, and there was no significant shortening of the bones. So this pattern was suggestive of fetal growth restriction over skeletal dysplasia. This is the graph showing the Doppler assessment of the fetus. So at around 24 weeks of gestation, the lady presented with decreased fetal movements, and on Doppler assessment, it was seen that there was intermittent absent end-diastolic flow in the umbilical artery. So after giving dexamethasone coverage for the lung maturity and magnesium sulfate for neuroprotection, we did a preterm LSCS for this lady at 32.4 weeks of gestation. Our male baby weighing 940 grams was delivered. The postnatal evaluation of the fetus of the baby was normal. To our surprise, this baby is now 5 years old and has achieved all the neurodevelopmental milestones timely, which make me believe and rethink that this pregnancy was at the verge of termination because of the fear of the unknown. But a collective effort by the team comprising of a radiologist, a fetal medicine specialist, a geneticist, and a neonatologist with the right amount of knowledge and expertise, along with the unwavering support and commitment shown by the couple, this baby came into the world against all the odds. So towards the end of this presentation, I would like to end on a note. It is more of a request to SFM and to my seniors to help us guide to come up with newer and more reliable nomograms for increasing our accuracy in diagnosing fetal growth restriction in the Indian population. As by using the charts available such as Intergrowth 21, we might be overdiagnosing fetal growth restriction with a relative risk of 0.39. And by using the locally available charts, we might be underdiagnosing fetal growth restriction because the population under study might be underweight or undernourished women. Thank you so much, everyone. Thank you, SFM, for giving me this opportunity, and a heartfelt thank you to Dr. Chinmay Umarji for giving me the guidance. Thank you so much, sir.
Yeah, wonderful presentation, Dr. Pooja. Very nice. So may I request all the attendees to please put your queries in the chat box. We will be taking all of them after the end of all the presentations. And now may I request Vishalji and Conference International to take over and play the trade partner videos. So welcome again. Now we move on to our fourth presentation, which will be by Dr. Vivek Mane. So Dr. Vivek, can you please share your screen?
Yes. Is it visible?
No, not yet. Yes, now it is seen.
It's seen now, sir.
Yes, your screen is visible. Now you please start your PowerPoint slideshow.
Yeah, slides are
Perfect.
visible, sir.
Yes, yes.
Thank you.
Go ahead.
So, good evening, respected teachers, seniors, and friends. I'm Dr. Vivek Mani. My today's topic is when one leads to another, but all ends well. This is the story of two anomalies. I will go through the case. A 29-year-old primigravida came for anomaly scan at 21 weeks of gestation, married non-consanguineously with no significant prior history. Now we'll see the images and the scenario loops. The fetus was in cephalic position. Situs was normal. This is the axial view of the thorax showing cardiac four-chamber view. Please look at the echogenicity of both the lungs and cardiac position. This is nose lip chin view. Upper lip appears intact. There is no evidence of cleft lip on either side. The transverse axial view of the palate showing the upper alveolar arch, posterior palatine line. Please look at the continuity of the posterior palatine line here. I have purposefully kept all three images in one slide. This is the kind of crux of my case. So please review these images and think of your diagnosis. We'll go through some cine clips that will make the things easier for you. This is axial view of the thorax showing the echogenic left lung compared to the right side with mild shift of the mediastinum towards the right side. And there is no large cyst. That's the echogenic lung with mild mediastinal shift. In the longitudinal section, we look at the domes of the diaphragm. Continuity is maintained that rules out the congenital diaphragmatic hernia. Also, the concavity is maintained, which is generally seen flattened in cases of bronchial atresia or the congenital high airway obstruction. There are no signs of hydrops like the pericardial or pulmonary effusion and ascites. We'll look at the diaphragms, domes of diaphragm. That's the dome of diaphragm. That's the echogenic lung lesion. And this is the right dome of diaphragm. The echogenic lesion in the left lung is getting supply from the pulmonary artery. So this is not getting any systemic supply, which is seen in the hybrid lesion or the bronchopulmonary sequestration. So now we come to the diagnosis of CPAM, that is the congenital pulmonary airway malformation, and this is the microcystic type. The cine loop for the next anomaly that's finding is this is the nose lip chin view. So upper lip is intact. Here there is no evidence of cleft lip on either side, and the primary palate is also intact, and there was no evidence of micrognathia. So that's the lip, nose, both the nostrils, and this is the primary palate. Now we look at the axial view of the palate. Here you can see the upper alveolar arch. There is discontinuity in the horizontal plate of the palatine bone. Both the palatine bones are slightly elevated and both pterygoid processes are seen. This leads us to the diagnosis of cleft, type 2 cleft of the secondary palate. Now we had two anomalies in the fetus. That's the discontinuity in the horizontal plate. So it was the CPAM with the isolated cleft palate. I was searching for the causes or the differentials for these two anomalies to coexist in a fetus. But however, I could not get any specific syndromic etiology in the literature. But yes, we had to rule out any chromosomal or genetic causes like 22q11 deletion, the Fraser syndrome, French syndrome before arriving at any definitive conclusion. So accordingly, we counseled the couple for the genetic testing. We did amniocentesis, while couple opted out of the whole exome sequencing. Both fish and the chromosome microarray that came out negative for any chromosomal or the genetic abnormality. Then couple decided to continue with the pregnancy. Mother went to her hometown for the delivery. So I don't have any follow-up ultrasound images. Full-term healthy baby was delivered. Baby did not need any respiratory support for after the birth. This was because CPAM might have resolved completely. Parents were a bit hesitant to share the images. However, they have confirmed the cleft palate. So now we'll go through some basics of these two anomalies. That's the cleft palate. The worldwide prevalence is 1 in 1,000 cases. So how does it happen? The primary palate, the fusion takes place during 4 to 8 weeks. It forms the four central incisors and extend up to the incisor foramen. Then the maxillary process develops palatine shells. They develop vertically downward on either side of the tongue. Mandibular process grows and expands. Tongue descends downwards, and it creates space for the palatine shells to elevate and grow horizontally until they fuse with each other to form the secondary palate. This also explains the reason behind the association between the micrognathia and the cleft palate. This fusion happens during the 9 to 12th week. So by 12th week, we have also the soft palate. So this image shows how the fusion takes place. A primary palate fuses in an anterior direction in a Y-shaped manner, and the posterior palate, it fuses in a posterior direction. It first forms the hard palate, then the soft palate, and lastly the uvula. So this gives us three types of defects in secondary palate. First would be just the bifid uvula involving the uvula. The second is the uvula and the soft palate. And third will be cleft in the uvula, soft palate, and the hard palate. So my case was having all the three defects. So a French group has given these two wonderful papers how to look at the palate. That's the technique to visualize the fetal heart palate. And in another paper, they have given the semiology. That's the classification of the isolated cleft palate. So now look at how to look at the hard palate. That's the secondary palate. So there are four things that we're supposed to look at the palate. While looking at the palate, when baby is facing towards the probe, both the eyes are towards the probe. At that time, we're supposed to look at the palate perpendicularly towards the hard palate. The four things that we're supposed to look is first is the alveolar arch of the maxilla, then the two pterygoid processes, then the horizontal plate of the palatine bone, and the posterior nasal spine. So they also given us four types of clefting. The first is the type 1, where you cannot see the nasal spine, but it's having the very high false positive rate. So we are supposed to look at the uvula. That will enforce our diagnosis. What I got in my case was the type 2 cleft palate, where both the palatine shells are slightly elevated and there is mild disappearance of the horizontal plate. In the type 3, there is further deepening of this gap, and both plates are looking literally parallel, giving a V-shaped defect. That's the type 3. And type 4 is the U-shaped defect, where you cannot see even the pterygoid processes. American group has given the two subgroup of this cleft of secondary palate. One is non-syndromic, that's not associated with any structural or any genetic etiology. And that's true isolated cleft palate, and the syndromic is having the structural any other structural abnormalities or any other genetic etiology. So yes, we had a diagnosis. Now comes the important part, is the counseling the parents. So in cases of isolated clefts, prognosis is good. Baby can lead a normal life. The only thing that we need is a multidisciplinary approach involving the pediatric surgeon and the delivery of the baby at a tertiary care center. Yes, surgical repair is possible with a 1 or 2 stage repair during the first year of the life itself. So do we advise the invasive test? Yes, there is structural anomaly. But in this case, in clefting, we get an increased risk of chromosomal and genetic abnormalities. That's why we have to test these babies. So what about the recurrence in the next pregnancy? So in isolated cases, there is 5 to 10% recurrence based on how many siblings are affected, whether parents are affected. And in case of syndromic, that's the non-isolated cleft palate, all forms of inheritance have been seen. Those are the autosomal dominant, recessive, X-linked, dominant, recessive. So we come to the next anomaly that we have got. That's the echogenic lung lesion. In my case, it is CPAM, that's the congenital pulmonary airway malformation. The worldwide prevalence is 1 in 1,000 newborns, and out of all the congenital lung lesion, it constitutes about 60% of the lesions. That's the most common lung lesion we get in the fetuses. So how does CPAM exactly happens? So there is abnormal course or any insult during the development between the 5 to 17 weeks of embryonic life. There is communication with the proximal airways. It may be abnormal, and the blood supply is always from the pulmonary artery, except the lesions like the hybrid lesions where it gets supply from the aorta. So based on ultrasound, we have classified this in 3 types. So one is solid, that is having a small cyst less than 5 mm size. We call it microcystic type, and the DDs would be for the solid lesion is pulmonary sequestration and the bronchial atresia. The cystic type is lesion is cyst will be more than 5 mm sized, that's the microcystic type, and the DDs are the congenital diaphragmatic hernia, bronchogenic cyst, and the mixed variant we're having both the components. So how we are supposed to report the lesion? So we're supposed to give the side, then we're supposed to give the size. So that's the most important thing in the CPAM. It can be given based on CVR, LHR, or MTR. The CVR is CPAM volume ratio. That's the most common thing we use for the follow-up also. So LHR is lung to head ratio. It's also given in the diaphragmatic hernias. That helps the pediatric surgeon, and the mass to thorax ratio. So type is whether it's solid or cystic, then the mediastinal shift, amount of shift, and the vascular supply, whether it's getting a pulmonary supply or the systemic supply, and any signs of hydrops. And we have to look at the amniotic fluid, because the bigger the lesion, it will give mass effect. That's the esophageal compression, and it will result in reduced swallowing of the fetus and give us a polyhydramnios. So what's the natural course of this lesion? So maximum growth happens between the 18 to 25 weeks. Then either it plateaus and stays there even after the birth. In most of the cases, it's going to regress or resolve, and we cannot see the lesion after the birth. So but does this lesions resolve really? So yes, 80% of these lesions appear to resolve in the third trimester, but it's not the true resolution. There are two factors we need to consider why it's not true resolution. One is the size of the normal lung parenchyma, that's increasing in size, but lesion is there in smaller in size. And the second thing is most important, that is the echogenicity of the lung parenchyma, that's going to be more echogenic, and we cannot see the lesion on the ultrasound. That's just the visual regression, not the actual regression. But yes, we can detect the lesion postnatally on X-ray and better on CT scan. So how do we measure the CPAM? It's with the help of perinatology site. We can enter the length, width, and height, and give the fetal head circumference, and then the site will give you the CVR value. In my case, it was 0.77. So why 0.77 is important? Because there are the cutoffs. Based on those cutoffs, we follow the cases. So how do we follow? Based on the CVR. CVR, when it's less than 1.6, at the time of presentation, the risk of developing hydrops is low, but there should not be any dominant cyst. So when it's less than 1.6, there are two types. One is less than 1.2. We follow up on bi-weekly basis till 26 weeks, because after that, anyhow, the lesion is going to resolve, or it may be not visible with the ultrasound. And then the CVR is between 1.2 to 1.6. So we need to follow up these cases on weekly once or twice based on the progression of the disease. When CVR is more than 1.6, or when CPAM is having any dominant cyst, irrespective of any CVR value, so there is high risk of developing the hydrops. So to follow up these cases twice or even thrice weekly. So now we had the follow-up, so we had the diagnosis. Now parents are going to ask us what next. So yes, if baby is not having any signs of hydrops, so we can ask them to continue with the pregnancy, because survival is more than 95%. But sadly, when there is hydrops, these cases are lethal and interventions are required. Microcystic type is having better prognosis than the macrocystic type. Invasive test, yes, we offer the invasive test, because any structural anomaly, we are supposed to offer the test. But here the less risk of any chromosomal or genetic associations. What about the next pregnancy? So there are less chances, there is very least chances of increased risk of recurrence. How do we manage these lesions? So when there is a microcystic lesion, the steroids have been tried. Then when it's a macrocystic lesion, the thoracoamniotic shunts are kept in place. There is a double flow shunt keeping one end in the amniotic fluid and another end in the largest cyst in the thorax, so that will keep continuously draining and keep the pressure inside the thorax to the minimum. So I had two different anomalies with a normal genetic outcome. So take home message from my case is, when you get obvious anomaly, look for other less obvious ones, just like the isolated cleft palate in my case. So if you have multiple anomalies, that does not necessarily mean the underlying genetic or chromosomal issue. Reassure the parents, but it should be based on the true facts. Otherwise, they may end up terminating the pregnancy. Give fair chance to every parent and the fetus. Yes, fetuses cannot speak on their own. So in the world of fetal medicine, we all are the fetal spokespersons. These are my references. Thank you all, and thank you SFM for giving me this wonderful opportunity. I would like to thank Dr. Khurana sir, Dr. Alok sir, Dr. Varun sir, for giving me this wonderful opportunity. Thank you so much.
Yes, wonderful presentation, Vivek.
Thank you, sir.
So now may I request Dr. Sonia to share her screen. There is a technical glitch. Sumit was supposed to present, but there is a technical glitch. So Dr. Sonia will be taking over. She will present. So Dr. Sonia, can you please share your screen?
Yes, sir.
Meanwhile, I request all the attendees to post their queries in the chat box so that we can take them at the end of all the presentations.
Sir, is my screen visible?
Yes, very well.
Should I begin?
Yes. Please start your
Yes.
PowerPoint
Yes.
slideshow. Yeah.
Good evening.
Dr. Sonia Patankar is a radiologist. She has done her MD from KM Hospital in Mumbai. She's trained under Dr. Mohit Shah sir at Abhipray in Mumbai, and currently she's working at multiple hospitals and clinics in Pune. Over to you, Sonia.
Thank you, Varun sir, for the kind introduction. At the outset, I would like to start by thanking my teacher and mentor, Dr. Mohit Shah sir, Dr. Ashok Khurana sir, Dr. Alok sir, and the entire team of Society of Fetal Medicine Greater Pune Chapter, Dr. Sabnis sir, Dr. Varun sir, and Dr. Chinmay sir for giving me this wonderful opportunity. My case today is all about following your gut instinct. We had a 34-year-old primary gravida who came to us at around 22.4 weeks of gestation for a second opinion anomaly scan. She had done a scan outside which had reported the presence of echogenic fetal bowel. The couple had been counseled that this did not have a very favorable prognosis and they were contemplating terminating the pregnancy. She had come to us for a second opinion solely for the purpose of confirming the diagnosis. And if our scan also showed a fetal echogenic bowel, they were going to go ahead with the termination. When we did the scan, we saw that there was increased echogenicity of the bowel loops in the lower abdomen of the fetus, which was almost equal to that of the iliac bones. So yes, we were looking at an echogenic fetal bowel. Our thoughts immediately went on to what could be the possible cause. Had the fetus swallowed the intraamniotic blood? Was there some underlying aneuploidy, some infection? Was there some GI pathology? Or we were just looking at a transient finding? A detailed structural evaluation of the fetus showed no evidence of showed no soft markers or any evidence of aneuploidy or infection. The growth of the baby was well within normal limits, and even the Dopplers were normal. A torch avidity test was done, and that was also normal. So basically, what we were looking at was an isolated echogenic fetal bowel. We explained the patient and the husband all the facts, counseled them that an isolated fetal echogenic bowel has a favorable prognosis with good short and long term neonatal outcomes. Reassured, the patient and husband decided to continue the pregnancy, and she came back for her second visit around 3 weeks later. And what we saw now flabbergasted us a little bit. The fetal abdominal circumference was markedly increased. It was more than the 99th percentile. And no prizes for guessing this was because of the presence of fetal ascites. There was also polyhydramnios at this stage, and the echogenic bowel was also persistent. So what had started as an isolated fetal echogenic bowel was now presenting with moderate fetal ascites, which was compressing on the diaphragm. So it was at this stage that we decided that we probably need to intervene. And so we decided to aspirate the ascitic fluid to relieve the pressure on the lungs and allow their development. Approximately 30 cc of greenish turbid fluid was aspirated. We also decided that we should go ahead with the amniocentesis at this time to see that whether we are probably missing something. And amniocentesis for FISH, CMA, CFTR gene mutation, and even TORCH PCR was done. And it all came out negative. By this time, a few more weeks had passed. Now the patient was around 32 weeks of gestation and she came back for her third visit. What this scan showed us that the fetal ascites had reduced significantly, but we could now see a segment, approximately 4 centimeter long segment of the fetal small bowel, which was persistently dilated. In addition, we could also see a small speck of calcification and a small speck of peritoneal calcification underneath the diaphragm. So now we had echogenic bowel, later on fetal ascites, dilated bowel loops, and peritoneal calcification. Our diagnosis was pretty much clear to us. Yes, we were looking at a case of meconium peritonitis with in utero perforation of the fetal small bowel. But the baby was growing well and even the Doppler parameters were normal. The baby was delivered at around near term, around 37 weeks of gestation in a tertiary care center. The postnatal radiograph revealed no evidence of dilatation of bowel loops. We could see some foci of peritoneal calcifications. This baby did not require any postnatal neonatal surgical intervention. The baby tolerated feeds well right from day 0. Today, the baby is healthy and is doing very well. So now what is meconium peritonitis? It is a sterile chemical peritonitis which results from in utero perforation of the small bowel, causing meconium to leak into the abdominal cavity and triggers an intense inflammatory response. It is a rare condition with an incidence of approximately 1 in 35,000 cases. Most of the cases are sporadic and the risk of recurrence if they are isolated is almost none. But 20% of cases of meconium ileus will have cystic fibrosis as their etiology. Now I'll take you through what is the pathophysiology. Whenever there is intrauterine bowel obstruction or ischemia, which could be due to many causes, it is most commonly due to small bowel jejunoileal atresia or a meconium ileus secondary to cystic fibrosis, but most cases remain idiopathic. Whatever be the cause, may it be an atresia or meconium ileus, it eventually leads to decreased mesenteric blood flow. There is transmural bowel necrosis and eventually the bowel perforates. When the bowel perforates, the meconium leaks into the peritoneal cavity and that triggers an intense inflammatory response, what we call as sterile peritonitis. Macrophages and giant cells get stimulated by the sterile meconium, form foreign body granulomas, and eventually it will heal with formation of fibrosis and calcification. There are three major anatomical subtypes of meconium peritonitis. If the perforation seals by itself, then by the fibroblastic reactions, then we get what is called as the fibroadhesive subtype of meconium peritonitis, which is the most common one which is seen. If the perforation does not seal, the meconium will continue to leak into the abdominal cavity and eventually get surrounded by the thick fibrotic membranes, forming what we all know is the pseudocyst in this cystic type of meconium peritonitis. If the perforation occurs in late perinatal life or maybe during labor, then there is not enough time for the perforation to seal, for localized sealing of the perforation to occur, and we get a generalized type of meconium peritonitis. What are the ultrasound findings that we get? Fetal ascites, it is the most common finding, but it is rather non-specific. If isolated, it should prompt ultrasound examinations to look for other signs of meconium peritonitis. If the ascites is small in quantity, it's okay. But if it is large, like as it was our case, it may be necessary to do an abdominal paracentesis to decrease the pulmonary hypoplasia, allow the lungs a chance to grow, and also reduce the inflammation. Echogenic fetal bowel is another sign which is often the earliest sign in cases of meconium peritonitis. We see increased echogenicity of the bowel loops. In the third trimester, this can be transiently observed because of the hyperechoic meconium which is seen in the baby's gut. But in the second trimester, this should warrant further evaluation to look for the underlying cause. The echogenicity of the bowel is compared with that of the surrounding iliac bone or femur, and depending on whether the echogenicity is less than, equal to, or more than the iliac bone, it is graded as 1, 2, or 3. But make note that we should use lower frequency curvilinear transducers for assessment of the bowel echogenicity, because higher frequency transducers will often erroneously overdiagnose fetal echogenic bowel. In addition, we can also see intra-abdominal calcifications, which are echogenic foci, either linear or clumped in a marked peritoneal distribution. They can be either focal, diffusely scattered throughout the peritoneum, or they could be lining the surface of the liver. We need to distinguish them from the inspissated meconium, which is transiently observed in the normal fetal gut, particularly in the third trimester. An absence of calcification favors cystic fibrosis to be the etiology. The poor intestinal peristalsis can cause swallowing difficulty and present with polyhydramnios. And as we all know in our CTs and X-rays, that the hallmark of intestinal obstruction is the presence of dilated bowel loops, and that can also be seen. So now let me take you back to the pathophysiology slide and link these findings to the pathophysiology. Whenever there is a bowel obstruction or an ischemia, there is basically stasis of the meconium which occurs, and that presents with an echogenic bowel. Eventually, the bowel will perforate, the meconium will leak into the peritoneal cavity and cause sterile peritonitis, which will be seen as ascites. It heals with fibrosis and calcification, and then we get our peritoneal calcifications. If the bowel obstruction persists, or in cases of meconium ileus, we will get presence of dilated bowel loops, and the poor intestinal peristalsis will lead to polyhydramnios. Zangari et al. Proposed a sonographic grading system for meconium peritonitis, where grade 0 is for isolated intra-abdominal calcifications, If they are associated with any one of either ascites, pseudocyst, or bowel dilatation, that becomes grade 1. Two of these findings together become grade 2, and all of them together become grade 3. Higher the grade predicts an increased need for that the baby may require a chance for surgical intervention in the neonatal period. Possible differentials include fetal ascites. We need to rule out fetal ascites, which may be due to other causes, but mostly in these cases, the bowel loops will be floating normally. The fluid will be more anechoic. A ruptured cystic teratoma will have coarse hyperechoic fluid, but we will also see a discrete intra-abdominal cyst, and of course, the bowel loops will be normal. Cystic fibrosis is a comorbidity that can complicate postnatal recovery in these cases. It is seen in approximately 20% of cases of meconium peritonitis. The low pancreatic enzyme concentration causes an abnormally protein-rich inspissated meconium. So all neonates who present with meconium type of intestinal features mandate screening for cystic fibrosis with the CFTR gene either antenatally or postnatally. The presence of pseudocyst, bowel dilatation, and ascites are three markers which necessitate delivery in tertiary care centers with advanced pediatric surgery abilities, because these are the cases who may go for neonatal surgery. As compared to the previous decades, the current post-operative survival in cases of meconium peritonitis has increased from 70% to almost 100%. This is also the case with non-surgical cases who do very well with conservative fluid and electrolyte management. And this is mainly because of the availability of advanced pediatric surgery and NICU facilities who can manage the immediate postnatal respiratory and metabolic crisis. Mortality remains higher for only those cases which are highly complex and are often have a delayed diagnosis or don't reach these tertiary centers in time. So basically, what did this case teach us? Echogenic bowel is not a diagnosis, it is a clue. An isolated echogenic bowel does not warrant counseling for termination of the pregnancy. It deserves patience, not panic. Serial scans can convert our uncertainty into diagnosis. Particularly in these cases, as what happened with our case, a single scan may not reveal all the findings and all of them may evolve over time. With the current advanced pediatric surgery and NICU facilities, meconium peritonitis is survivable and also treatable. And last but not the least, the importance of careful counseling. So whenever presented with an abnormal fetal diagnosis, most parents instinctively will ask us, what can we do to save the baby? It is our responsibility that we honor this instinct, provide them with all the accurate information, give them an overview of the prognosis, discuss management options, and guide them through this uncertainty to make an informed decision. Because as radiologists, as imagiologists, we are actually more trained to diagnose an anomaly. But actually, what is an anomaly for us is a baby for the parents. We need to maybe look a few steps beyond, rather many steps beyond, and see what it is in our power that we can do to actually save these fetuses. Of course, we cannot fight this battle alone. In fact, the real heroes of this story may actually be our obstetricians, neonatologists, and pediatric surgeons who take these diagnoses from our hand and convert it into a thriving, healthy newborn. Because together we will win. Thank you.
That was a wonderful presentation, Sonia, and a wonderful message that you have given after the talk. Truly, that is what we all need to do. Beautiful.
Thank you, sir.
So, may I call the next and the last speaker of the day, Dr. Sumit. Sumit, will you please share your screen?
Yes, sir. Is my screen visible and my voice audible?
Yes. Your screen is visible. You are audible. So Dr. Sumit is a radiologist. He has done his MD radio diagnosis from KEM Hospital, Mumbai, following which he got trained under Dr. Adinarayan Matham sir in Bangalore. So over to you, Sumit, for the last talk of the day.
Thank you. So good evening, everyone. At the outset, I would like to thank the entire SFM team for giving me this opportunity to present the curious case of the innocent coaptation. So I'll directly jump onto the case. So the first case was a fetus referred to us at 22 weeks of gestation for a routine anomaly scan. What you see is an axial 4-chamber view in which you can see that all the chamber sizes are normal. Both the ventricles are pumping normally. both the AV valves are also opening normally. But moving on to the three-vessel trachea view, what one can see is that the aortic isthmus is very narrow. The transverse aortic arch is also very narrow. It's almost equal to the size of the SVC. On color flow, what we can see that there are two features that we can see. First is that there is aliasing in the aortic flow. And second, there is presence of diastolic runoff, which means that the flow across the transverse aortic arch is also seen during the diastole. Ideally, in great vessels, the flow should happen only during systole, but here it's happening even in diastole, and this becomes perceivable if we use the color M mode. On using the color M mode, what we can see here is that this blue strip, vertical blue strip, corresponds to the flow happening during the systole of the ductal arch and of the aortic arch. But the tail, the color tail that you see, which is happening in diastole, that's the flow happening across the aorta during diastole, which is called as diastolic runoff. The diastolic runoff was initially described in pediatric echocardiography, but it can be also seen in fetal coarctations as well. The velocimetry and cardiac biometry also showed a narrow aortic isthmus with an increased velocity across aorta. So this was diagnosed as having coarctation of aorta. Now, a second case was referred to us at 32 weeks of gestation for hypoplastic left heart syndrome. This is the axial view of the fourth chamber heart, in which you can see a significant ventricular size discrepancy, where the right ventricle is larger than the left ventricle. On three-vessel trachea, you can see the aortic isthmus is quite narrow. On flat, again, fourth chamber, you can see that both the tricuspid and mitral valve are opening normally, as well as the aortic valve is also seen opening normally. This is the color flow across the tricuspid and mitral valve. You can see a very thin strip of column of blood is seen flowing across the mitral valve in forward way. There was forward flow across the aortic valve as well, which is seen here. On three-vessel trachea view on 2D and color together, what you can see here is that there is forward flow in the ductal arch, but there is an aortic isthmus reversal, which is seen here. So ventricular size discrepancy, narrow aortic isthmus, and reversal of flow in the aortic isthmus all pointed to the possibility of coarctation of aorta. But there was one more finding which was seen, which was more evident in the basal four-chamber heart view, which was this. There was a presence of a membrane-like structure which was sitting just under the mitral valve. So these two cases, they had a common diagnosis of coarctation of aorta, but both of these cases had another common finding, which was excessively moving flap of foramen ovale or redundant flap of foramen ovale. So the primary pathology was in fact a redundant flap of foramen ovale, which led to coarctation of aorta. Before that, we need to understand how the foramen ovale works. So the interatrial septum is composed of two septums. First is the septum primum, which has an opening above, which is called as ostium secundum. Second one is the septum secundum, which has an opening below, which is foramen ovale. Now the septum secundum is towards the right atrial side, and the septum primum is towards the left atrial side. So if you open up the atria from the right side, you can see a hole which is inferior, which is the anatomical foramen ovale. And if you open up the atria from the left side, you see a hole which is above, which is also the valve of foramen ovale. So these two form the interatrial septum. Now, the function of foramen ovale is to allow blood flow from the ductus venosus to go into the left atria. And the way it has to go is that the blood from DV enters the right atrial cavity. It enters through the foramen ovale, anatomical foramen ovale, courses through this narrow path between the two septums, and then comes into the left atrium via ostium secundum. But this appears a little constricted, considering that almost 76% of the left ventricular cardiac output is composed of the flow from ductus venosus. So this becomes the physiological foramen ovale, but it appears constricted. But thankfully, the foramen ovale is not, the flap of foramen ovale is not a static structure, but it's a dynamic structure. The flap, which is nothing but septum primum, keeps on moving towards the left atrial side. So when it is open, the blood from the ductus venosus directly goes in a straight fashion towards the left atrial side. And this becomes the physiological pathway for the blood to go from DB to left atrium. So to understand the path, the longitudinal section of this path, we need to take a cross section in sagittal plane, where you can see this is the right atrium, this is the left atrium. IVC is draining into right atrium. Umbilical vein brings the oxygenated blood to the body, and then there is ductus venosus connecting the UV to the infundibulum of the IVC. Septum secundum is towards the right atrium. Septum primum is towards the left atrium. Now, considering this arrangement and the pressure and the velocity of blood flow across the ductus venosus, one can see that the flow from the ductus is preferentially directed towards the left atrium, and the flow from the IVC is preferentially directed towards the right atrium. In fact, the inferior edge of septum secundum, which is called as crista dividens, helps in division of this blood flow. So this is a 4D rendered image of heart in lateral four-chamber view. And in this, you can see the flap of foramen ovale, which is seen moving in the left atrial cavity. So if you want to see how longitudinally it looks like, you have to hold this part and then rotate 90-degree the probe, and you will get something similar to your bicaval view, where the top one is the right atrium, the bottom one is the left atrium, and this is the flap of foramen ovale, which is moving downwards. This is the IVC. So naturally, the flow of ductus venosus is directed towards the left atrium, and this is the physiological pathway for the blood to go from DB to LA. But you must be wondering why the only septum primum moves and why not septum secundum moves towards the right atrium? Why that is not more mobile? And the answer lies in histopathology. This is the image of a 30-weeker fetus, this image of interatrial septum. The top one, which is thick, is the septum secundum. It's more rigid. And as you can see, the bottom one is the septum primum, which is a very thin mobile structure. And that's why the flap of foramen ovale, the septum primum, moves towards the LA to allow blood flow through the foramen ovale. The next question comes is, how do you measure the flap of foramen ovale, or how do you measure foramen ovale diameter? If you measure in this fashion, end to end in a horizontal manner, you end up measuring the anatomical foramen ovale, which is measured in postnatal autopsies. But to measure the physiological pathway, you need to do a measurement starting from the maximum excursion of the flap of foramen ovale till the septum secundum. So this is how you measure the foramen ovale diameter. So if you have a lateral four-chamber clip, you just store the clip and move back to a point where you can see the maximum excursion of the flap, and then measure its length from the septum secundum. Now, there are two problems that can happen with flap of foramen ovale. First, that it moves too much, in which case it is called as redundant flap of foramen ovale. Or sometimes it moves too less, in which it's called as restrictive foramen ovale. So this paper in 2024, published by a Chinese group, gave us an index which is called as the atrial septal excursion index. They took a ratio of the diameter of foramen ovale divided by the left atrial diameter taken just above the AV valves, and this ratio was taken either on M mode imaging or 2D. If the ratio was more than 0.65, which means the flap was moving way too much into the left atrium, then it was called as redundant. But if the flap was less than, if the ratio was less than 0.4, it was called as restrictive. Now, how does a redundant flap of foramen ovale results in coarctation of aorta? As you can see here, this is a four-chamber heart, and the flap is redundant indeed. So if you see a still image, this is the left atrial border, and this is the flap of foramen ovale. You can see that it is occluding the mitral inflow. So the mitral inflow into the left ventricle, which was supposed to happen in this fashion, now because of the excessive movement of flap, the effective left atrial diameter will get reduced, and the flow towards the left ventricle will also get reduced, which will eventually result in coarctation of aorta. And this was proven in 2020 by Flaminia, Vina and group, in which they studied three groups of fetuses. First group was fetuses with isolated true coarctation of aorta, which was confirmed postnatally as well. Then they had a group with redundant flap of foramen ovale presenting as coarctation antenatally. And the third was a control group of normal fetuses. They used certain parameters to categorize the redundancy in three types. The first one was the excursion index, which is foramen oval flap diameter divided by the left atrial diameter. The second was presence or absence of ventricular disproportion. And there were other features. So they categorized the redundancy in three categories. The first one was a normal ratio and no ventricular disproportion. It was category 0, which is normal. Ratio more than 0.65 with absent disproportion, category 1. Ratio more than 0.65 with RV more than LV significantly, that's category 2. Category 3 was ratio more than 0.65, presence of ventricular disproportion, and transient prolapse in foramen ovale or mitral valve orifice, which means that the flap was moving way too much such that it was impinging on the mitral inflow, mitral valve, or towards the right atrial side. That was given as category 3. Now, the interesting finding they found was the imaging features in category 2 and 3 versus the imaging features in isolated true coarctation of aorta. There was absolutely no difference. The only difference was postnatally, the fetuses with true coarctation did present with coarctation, but those fetuses with redundant flap of foramen ovale were completely normal after birth because of increase in the pulmonary venous return and spontaneous closure of the flap of foramen ovale. So now coming to both the cases, both these cases had redundant flap of foramen ovale indeed. My first case was a 22-weeker. So listening to the diagnosis, the couple decided to terminate the pregnancy. But these parents, when we explained to them that there is indeed coarctation, but the reason is possibly this echogenic membrane that you see, which is nothing but the redundant flap, we kind of reassured them that this subset of fetuses carries better prognosis. So in this still image, you can see this is the mitral valve. This is the redundant flap of foramen ovale. So they continued the pregnancy till term. A healthy baby girl was born, and this is the pediatric echo report on day 1 of the baby's life, in which you can see that the left ventricle has absolutely normal morphology and function. There was a 5 millimeter ASG which spontaneously closed. The aorta was absolutely normal. Prenatal life, there was reversal at aortic isthmus, but postnatally the aorta was absolutely normal. The only positive finding, was presence of severe pulmonary arterial hypertension, which was managed conservatively for her. This case came to us in 2019. So now the girl child that you see on right, she's 7-year-old and absolutely fine. So whenever you encounter an unexplained chamber size discrepancy, especially in third trimester, or when you have a suspected case of coarctation of aorta, do have a look at the flap of foramen ovale, because if it is redundant, it carries a better prognosis as compared to those in which the flap is moving normally. My takeaway message is that, as Dr. Sonia said, as sonologists, we are more focused on finding abnormalities, but once you find an abnormality, also find the reason to save the fetus. Thank you.
Amazing presentation, Sumit. So 6 of you have done a great job. All 6 of you have done beautiful presentations. And as Dr. Sonia and Sumit said that, as imaging specialists, our job is to diagnose things, to inform the parents, help them take a decision. And rather, we should not be writing death sentences for these fetuses. So as we saw, of the 6 cases that we had today, of the 6 presentations, except for Devashree's, 5 of them continued and did well. Although in the second case, which was presented by Rahul, as Alok sir said, the couple was lucky that they went against the genetic part and still came out triumphant. That may not be the case always, but as imaging specialists, as obstetricians, as fetal medicine specialists, our job is to give or to paint a correct picture in front of the couple so that they can take an informed decision. So with this, we take on the questions in the chat box.
Yeah, so wonderful presentations by all the young guns. And they navigated us through a complex array of fetal anomalies, moral dilemmas, challenges in counseling. So amazing presentations. Uh, it is very, very overwhelming to see their dedication, the clarity of concepts, and their presentation skills, and especially Sumit's presentation was absolutely mind-blowing. What do you say, Khurana sir?
It's fascinating to see where slides have come. It's amazing to see how the current generation is taking things ahead. They blend new technology with current thinking so beautifully. And some of the ways in which they convey their messages through this new formatting of very artistic slides as well as slides made from AI is a grand teaching experience. There is a tendency all over the world to look down upon slides that are created by AI because people feel it doesn't take the effort by the author in creating these slides. But the fact is, a slide is supposed to convey a message most effectively. And if this is the means of communication and it's going to stick in people's head, absolutely fantastic. What the group have done today is again really analyze their patients very carefully. They've gone into the psychology of their patients, and that is an amazing feature. And it's a common thread through all 6 presentations. Congratulations to the mentors for tonight, you and Varun, and congratulations to all 6 speakers for putting together such fantastic presentations.
And Mohit sir, are you happy with the presentation of your fellow
Oh, she's always
and the others?
she's always been very brilliant. But more than happy. I'm so satisfied to see that we are handing over the baton to the right hands. The very satisfying feeling to see the student, the young guns, do so well in their field, in their respective areas. It is indeed a very satisfying feeling. All of them worked up their cases, good images, good follow-ups, good genetic workup. And as I always say, the most important part is talking with the patient. Talk to the patient, counsel them, and that is what probably will, make the most of the difference which they have shown today. So hats off to all 6 of you. Thank you, Alok, Varun, Khurana sir, as always. Thank you, Santosh, and the Pune chapter for holding this. I'm really proud of all 6 of them. Thank you.
Okay, so we'll quickly go through the questions which are there in the chat box. Some of them have been already answered, but we'll take a few of them. The first is for Dr. Rahul Kataria. Uh,
So because of some family issue, he's not
Acha,
there.
he's
So is it
not
okay
there.
if I take his question?
Yeah, so the question is that in his case, there was a rocker bottom foot and a whole exome sequencing was done, and that was normal. So is it enough to predict that the neural developmental outcome is going to be normal?
So first of all, Neha ma'am has said that in the presence of positive USG findings, can we assure the couple about neurodevelopmental normalcy? Even in the absence of any USG findings, we cannot assure the couple about neurodevelopmental normalcy. So that is beyond ultrasound or beyond anybody's reach. Secondly, having negative WES report in this case, can we reassure the parents that the baby will not have any other genetic conditions or neurological issue? So we counseled them for whatever tests we could and whatever they could afford. They have opted for this and they know the pros and cons and limitations of the testing. We certainly cannot reassure them about everything that they wish to know. What we can tell them that whatever this test covers has been covered, and if the test returns as normal, then those things are not there. We cannot reassure them on every aspect, certainly not on other neurological issues.
Yes, because the whole exome sequencing will miss out certain parts of the genes, which will, it will not cover everything. But yes, having a whole exome sequencing turning out to be normal will reduce the chances of having poor neurodevelopmental outcomes. Your experience with this, sir, Khurana, sir?
We're very straightforward. Whenever we suggest a genetic test, we always tell the patient what it's being done for and what are the limitations. As long as your pre-test counseling is done, the question of this question does not arise. Of course, every patient will get post-test counseling, and we will remind them that these are the basics of counseling. But as long as we've driven this message home in the pre-test counseling, such situations really should not arise because the patient knows that after the pre-test counseling, that there are no guarantees. So this is a very, very important part of pre-test counseling, that we make sure that we drive this point home, that by paying for this test and getting this test done does not mean that your child will get a free ticket to Harvard Law School.
Uh, So the next query is for Dr. Pooja Verma, and the query is that in her case, uh, was there a confusion between this skeletal dysplasia versus early onset FGR? So why did she think of an early onset skeletal dysplasia rather than an early onset FGR? Dr. Pooja, are you
So,
there?
yes, sir, I'm there.
Yeah.
So we did, so our provisional diagnosis was primarily early onset FGR only. But the findings that we had, primarily the long bones were short below 3 standard deviation. And of course, the femur length to foot length ratio was nearly 0.74. So we would wanted to keep the possibility of skeletal dysplasia in our mind before actually declaring it as something normal and which something that can be continued after serial monitoring. So we did a pre-test counseling, and while offering the test, we of course made them understand that what are the yield of the test being offered. But despite of our efforts, we actually wanted to get the WS trial done for this patient and of course for the parents as well. But then because of the time and money constraint, they opted out for this particular test. Yeah.
Yeah, so the other leading question to this was that why was not WS offered
Right.
and why FGFR3 genes test panel was offered. So you
Uh,
answered this, that
the
there
reason
were
was money constraints, primarily.
money constraints. Dr. Santosh, in your practice, do you often face this
Yeah,
confusion
yeah.
between?
This is very common, and we tend to lose quite a bit patience if you insist on doing trio. So most of the time we do have to do a tightrope walking, and we'll have to say, okay, ठीक है, at least get an WS done for the fetus, and then if something like wows and all come, then maybe you both may need to get checked so that we'll get a trio proper. But this is very common, and even though we try to limit the cost, parents are not ready to spend so much of money. So they take the easy option out of terminating. Then that kills the whole purpose of the test. So we need to uh, manage each case on its own. But we face this quite often.
So, Khurana sir, a question for you. Is it possible based on imaging alone to differentiate between early onset FGR versus skeletal dysplasia?
Certain things, yes, associated abnormalities and the femur foot length ratio. They can be useful, but they cannot be conclusive. And the other thing, of course, is looking at the thorax and making sure whether the thorax looks good. Then there's specific pointers that we find, for instance, the bone architecture. But if all that is equal, then it is tricky sometimes. And we know that because we are a protein deficient nation, very often our femur also slows down in growth restriction. And the degree to which it slows down in a skeletal dysplasia is classically supposed to be much less. But we know that that degree of slowing down happens in the late second trimester and not in the earlier part of pregnancy. And therefore, we are stuck with borderline readings from all sides. The question then arises is how much importance do we give, and should we gamble or should we not gamble? If we don't gamble, we will certainly lose a large number of normal fetuses, which is not correct. And if we do have this liberal law with the MTP that if anything is going to evolve into something very bad, then we can terminate late. The other thing that we have to make sure that we will never terminate a skeletal dysplasia on the basis of stigma of society. So we have to weigh all these things together and then make a final conclusion. And these would all be points in counseling. What I've added on now very easily is a completely radically different approach to this. And that is to assess placental function. I don't go by Doppler alone because abnormal fetuses can have an abnormal uterine artery flow, and growth restricted fetuses can have a uterine artery flow which is compromised. What I do is immediately run an SFLT PLGF ratio. It tells me how bad is this
Okay.
placenta in terms of disease. And it's revolutionary in what we can analyze with this. And you get to recognize a bad placenta weeks ahead of a critically bad placenta. And so I'm using it increasingly to differentiate between this rather than thinking, is the father short, is not the father? And in Delhi, I'm always stuck. I never know who is the father. So therefore, I go in entirely by something which is objective, which is SFLT PLGF ratio. So this is the way I now work and differentiate bad from good placentas. And then when I'm looking at the skeletal dysplasia, sometimes I would run some additional genes, which I tell the lab about that, look, when you're doing your sequencing, please make sure that you also include this particular set of genes, which means I will go through my FGFR2, I'll go through FGFR3 and so on and cover them all up. The next question is what Santosh brought up very beautifully, and that is that the world keeps saying, do a trio sequencing, do a trio sequencing. Hello, 90% of our results from a whole exome sequencing can be interpreted without a parental exome. And then the same people tell me that, look, today you will do QF-PCR first, then you will spend this many weeks on a microarray, then you will do an exome sequencing, and yet they say to save time, I want to do a triple exome sequencing. What is the logic in completing both exercises by 7 weeks from the time of diagnosis? I fail to understand. Guidelines from all over the world seem to be so outdated before they come. And technology seems to be moving at such a rapid pace that you and me have to put our brains together. We have this new tool where the exome sequencing covers up the vast majority of our microarray. Then why am I making so much noise about it? Yes, it takes a greater effort. Look at the effort that every imaging specialist spends on a particular fetus and compare it to the amount of time a geneticist spends on looking at one set of exomes. There is no comparison.
There's no comparison.
So if I'm doing a deep phenotype, why can't you be doing all of this yourself? And your pipelines should be like that. And if I'm developing my AI, why can't they develop their own AI? So these are modern dilemmas that are not even dilemmas. They're very straightforward. That the imaging chap is going on and on and on from 7 a.m. to 10 p.m. and the geneticists have a 9 to 5 job. That's not fair. So therefore, I absolutely insist that we have to be practical, exactly as Santosh said. Patients being dropped, babies being dropped without adequate workup, and we can't afford that. Partial workup is far better compared to guidelines. That zones where I need to consider extended genetic evaluation for the parents is not the vast majority, and therefore I will do a fetal exome sequencing and then do the rest. And I will give every patient the option of a trio exome sequencing, undoubtedly. But I'm not going to spend too much time on my microarray, irrespective of what any genetic academy thinks anywhere all over the world, because we have to keep pace with time. So this is something that we have to learn, that guidelines take long and guidelines can be outdated before they arrive, and that guidelines need to evolve faster than technology. And that's why at SFM we keep working and working and working. And what was a guideline day before yesterday is no longer a guideline today. And that's why we have so many people working together to make sure we move at a pace that is best for our patients. Our patients are very desperate because we have a different psychological structure and we have to cater to it. And each one of our patients today that was discussed, each one of our fetuses had a specific psychological overtone during that presentation. And that was covered up in the conclusion. And I think that's marvelous that we sensitize our younger generation to all of this. I want to specifically thank each one of them for bringing these points up.
Absolutely.
Fantastic.
Correct.
Absolutely.
Yeah.
Sir, I think Alok sir has brought up a great point. We keep on discussing, and now that sir has spoken about WS so well, then I think all of us, because this question keeps on popping in our heads also, when most of the CM is already covered in WS, why are we going to do the test again and prolonging the time as well as the cost? So I think there is no hindrance for us to, give WS to all the patients and ask the labs to cut down the cost. And I think the labs will listen to us if we keep on insisting that we will do WS in all the cases. Let's do with the fetus first, and if something happens, obviously we can always fall back for the trial. Thank you, sir.
I
Yes,
think
sir.
Khurana sir has shadowed a war with the geneticists of the country. I think what he means is that they should be pushed a little more and bring us the country-specific solutions to the problems that we face.
Yes, and we need to sit down together at the table. We've tried this before. We've tried it with the SIAMG, and the geneticists sat down and discussed what was peculiar to them. And then when we did receive these guidelines, they seemed okay to follow. But by the time they went into publication, they seemed to be outmoded in a year's time. And it took 2 years to prepare. So everything changed in the meanwhile. So if what use is a mouse chasing that cheese when someone goes and moves the cheese by the time the mouse gets to the cheese? So it's really a question of who moved my cheese. And therefore, we will work towards this, and we will continuously work towards this.
Yeah.
And our weekly exercises always work towards this. What is optimal today and what has changed today? And in fact, if you look at the chat box, it's exactly the same story. What do I do with this particular case today? Yeah. Excellent.
Absolutely correct. Yeah.
Yes.
So
We have a
then
few more interesting questions. Yes.
Yeah, some non-controversial questions. So the question for Dr. Vivek Mane is that how does the palatine shells fuse anterior to posterior, posterior to anterior, and why does this matter? Dr. Vivek?
Yes, am I audible?
Yes.
Yeah.
So can I share the slide?
Yes.
So that I can
Please.
explain this?
Yes, you can.
Yeah, of course.
So that's the Y-shaped fusion that's happening in the primary palate, and that's the secondary palate. Those palatine shells are fusing in a posterior direction. The hard palate, this is the incisive foramen, so that fusing in the posterior direction. First to fuse is the hard palate, then the soft palate, and lastly the uvula. So how the defects happens is first you can get a defect in the uvula, that's just the wifid uvula, and then the secondly you will get a defect in the uvula as well as the soft palate, and thirdly you will get this defect that is the involving all the three parts, but at the same time you may get a normal alveolar arch with the normal and intact lips. That's why we are supposed to look at the posterior palatine line.
Yeah, so the short answer is that it fuses from anterior to posterior, and yes. And if you see that the uvula is intact, does that rule out cleft of the palate? Dr. Vivek?
Sir, hello. Yes, sir. So looking at the uvula is a bit tricky. One thing is we may get confused with the vocal cords. Then second thing is looking at the uvula itself, we need some amount of fluid in the oral cavity. So that's not always the case. That may not be possible always. In order to look at that in a exact mid-sage or a better way in a coronal plane. So we may not get the ideal sections, ideal planes. So while looking at the hard palate, that's a bit easy, I feel, because whenever baby is facing towards the probe, that's when we are looking at both the eyeballs and the lenses equally. So at that time, we can just go downwards and look at the upper alveolar arch, and at the same time just give a 30-degree tilt to the probe, and then we can get a posterior, nice and posterior palatine line showing both the pterygoid processes.
Varun is a great expert at the posterior palatine line. So Varun, any pointers from you how to get it nicely?
Yes, sir. Because ISWA guideline tells us that we have to document both the orbits, and typically we wait for the orbits, for the fetus to be supine, even for the heart. So when the orbits are facing 12 o'clock, even if we close our eyes and take a sweep from the orbits to the mandible, should the fetus be in neutral or slightly extended position, even if we don't want to see, we will still get the posterior palatine line. So personally, I feel that is the easiest way. But if somebody has to look at the uvula, then I would suggest they should be looking at the uvula in the coronal plane so that they do not mistake uvula for something else and something else for uvula. So if we have to look for the uvula, then my suggestion would be to look at it only in the coronal plane and do not do it in axial or any other plane, because then it can be mistaken for other structures also. And the second thing is, say suppose if I don't see the uvula, what next? I have to look at the posterior palatine line anyways. So then why not look at the posterior palatine line directly? Why wait for the uvula? And if I miss, say suppose if I'm not in my protocol, I don't see the uvula. If I don't see the uvula, that means I'm missing out on type 1 cleft palate, which is clinically not that significant, or it's not something which is life threatening. Neither is type 2 or type 3 cleft palate, but at least by looking at posterior palatine line, I can counsel the patients better that there is a type 2, type 3 or a type 4 cleft. So my suggestion is posterior palatine line is better than uvula, but this is only my humble opinion. Everybody need not concur with that. Whichever way it is feasible, as you said in the previous talk, Bimal sir also said, and I think DP Singh sir said probably, whichever is easy. If you can see, if you can get the uvula, get the uvula. If the fetus gives you position for the posterior palatine line, so be it, do it. But in either case, we should be trained to see, I mean, our brain should be trained to look at both the structures so that when the time arises, we are better equipped to deal with it.
Absolutely true. Dr. Khurana sir, your opinion,
You
anything you
there's two things we tend to miss, or what should I say, mix up. There is no doubt that the alveolus has its own way of fusing, which is the alveolar ridge of the maxilla, and the adjacent part of the anterior palate fuse independently of the rest of the system. There is the soft palate, which fuses from posterior to anterior. The rest of the story is that just because a palate fuses in a certain manner, does that exclude or confirm the possibility of an isolated cleft in any part? We do understand it's not a question of the way fusion progresses, but why it doesn't happen in certain parts of the palate. And that is the problem. The problem is exactly like we used to think about the spine. We used to think there was a zipper from head to the middle and a zipper from the sacrum upwards. But we realized that there is no such zipper system, that there is a fusion which generally proceeds from up to down and down to up in the spine. And in the palate, it is usually posterior to anterior. But why does it stop at a point and then why does it continue again is something for which we don't have an answer. And teratogenicity studies have proven to us that yes, there would be certain drugs that would cause isolated effects. Because of this, we've had to look at embryology again and realize that we can't use general rules of embryology to exclude defects. So the isolated palates will always be missed because we only look at the edge landmarks and we don't look at the rest of it. And it's not possible for us in any practice to look at the whole palate all the time for all our babies. And therefore, we will always miss certain things. So we shouldn't mix up the embryology or the time-bound embryology of the palate with the kind of defects that we see. It depends on what has got destroyed in that fusion process at that moment in time when that was developing in the embryo before the embryo was 6 weeks old. So this is the new insight that we have from embryology. But the landmarks that we follow, which is the uvula, the posterior palatal line, and the anterior alveolar margin, is something that we should follow for everything.
Fantastic. So let's move on to the next question. And the next question is for Dr. Sonia. How early can meconium peritonitis occur in a fetus?
Generally, sir, meconium starts coming in the bowel around 11 to 14 weeks. That is what it says. Meconium peritonitis generally occurs around 18 to 20 weeks, but there have been cases or case reports where it has been diagnosed as early as around 16 weeks as well.
Yeah. So Varun, have you seen any earlier case? Dr. Santosh,
no,
your
sir.
experience?
Most of my cases are around 20 to 24 weeks. I haven't seen an 18, 20 weeker, no.
Yeah, but they can occur early, very, very early. They can occur around 12 weeks as well. So the bowel, when it is developing, it can rupture, but the idea is that it heals up.
Yes.
And majority of the times there are no consequences, except yes, you have to counsel about the,
Yes.
sometimes because of the adhesions, the bowel obstructions can occur after
Great.
birth.
Yes, sir.
after birth, as Dr. Anthony Roberts is pointing out. He's a renowned pediatric surgeon from Bangalore, and he makes up a very valid point that we have to counsel about these meconium peritonitis, that postnatally, some of the babies, they can develop obstruction,
Perforation. Yes, sir.
perforation, etc., etc. Okay, so then we move on to the next question. Mhm. We have covered uvula and CPAM again. Dr. Vivek Mane, Dr. Anthony says that the CPAM has a very good prognosis, majority of the cases. So that is not something which should, scare the parents. We should be scaring the parents with.
Yes.
All right. So for Sumit, we have a question: how to take isthmus to duct ratio? Did you cover this in your presentation?
No, sir, but I've added one image right now. If I can share my presentation.
Sure. Of course, you may. We give you only 12 minutes, and there's just that much that you can cover in those 12 minutes. And we give you an hour and a half of discussion, which is unlimited. So you're very, very welcome to add this image. Excellent. Yes.
So I just took this from internet right now.
Correct.
So this is the transverse aortic arch, and
Mhm.
the point where both the aortic arch and ductal arch meet, that's the point where you should take the duct and the isthmus ratio. And I have taken the same ratio in my own case. You can see this is the ductal arch and that's the aortic arch. So this is the aortic isthmus and that's the duct. So the ratio is normally more than 0.74. If it's less, then it can indicate that the aortic isthmus is small.
Perfect. Perfect. Sumit, I will have to learn from you how to make those beautiful diagrams and 3D renderings. I'm really amazed by those diagrams.
Thank you, sir. Thank you,
We
sir.
should make use of Sumit for all our
Yeah.
abstracts, you see.
Yeah.
Make sure that he will now design our abstracts for us, which we release on social media.
Yes, sir,
So, Alok, will you
definitely.
please make a note and make sure
Yes,
that Sumit's
already.
talent is very well recognized, because one of the most brilliant illustrators I've come across in modern times.
Sumit, that's a
Thank you, sir.
fantastic. Alok sir saying that he needs your help is like unheard of. So
But I'll
you
learn
are
more.
something more. You are a boss already.
No, sir. I'll
Yes, he
learn more in
is.
the process.
He is. So one more question for you, Sumit. So what is the role of the pulmonary venous flow pattern when there's a redundant foramen ovale, and this is causing significant mitral flow obstruction? So should we check the pulmonary venous flow in such cases when we have a redundant foramen ovale?
Sir, I could not find a paper dedicated to this particular pathology, but there are papers discussing the role of pulmonary venous return in cases of HLHS with
Right.
respect to foramen ovale. So, in that particular scenarios, the worse the pulmonary venous return, the worse the fetuses do postnatally because there is pulmonary venous hypertension that develops and then the neonates land with pulmonary arterial and venous hypertension, which is difficult to treat. But if both the ventricular chambers are pumping normally, if the contractility of the left ventricle is maintained in spite of in spite of returning flap, so I think it should not affect much. Although even I don't have much experience in this, I think seniors can guide me in this.
Yeah, so I don't think that the pressure inside the left atrium is going to increase because of the redundancy of the flap of foramen ovale. If it is restricted, the flap is restricted, the foramen ovale is restricted, yes, then there will be increase in the pressure in the left atrium, and that will reflect in the pulmonary venous waveform. But in usually, as you said, that uh, the pulmonary venous waveform is going to be normal when there is a redundancy of the flap.
Yes, sir. Thank you, sir.
Okay. Then we have lot of accolades. Everybody is appreciating the presentations. Very well done. Another question for you, Dr. Sonia. Uh, what are the counseling points in cases of suspected meconium peritonitis if you diagnose them in the late second or third trimester?
Sir, we need to explain the pathology to the parents that probably this perforation may seal on its own, but there is a possibility that the neonate may require surgical intervention. We need to counsel them that they need to deliver in a tertiary care center and refer them to our pediatric surgery and neonatal colleagues so that they can take over immediately and stabilize the neonate, and if necessary, any intervention can be planned.
And what about the genetic testing in such cases? Would you offer genetic testing?
Sir, if there is, if it is, we can offer a genetic testing, particularly if you're looking for a CFTR for cystic fibrosis. At around, but depending on how much time we have, how late is the presentation, we will have to tailor that depending on that.
Khurana sir, meconium peritonitis and CFTR. Should we offer CFTR testing in all the cases of meconium peritonitis?
I like to offer it for all of them for the very simple reason that because that knowledge is in place, patient would say, why did you not do it? And I don't want a child who's infertile, and I don't want a child who may become a respiratory cripple. The patient can deny it in case they don't want it, or in case they think they can't afford the additional expense, but I offer it to each one of them. So whatever is available everywhere, I offer it. So with, in fact, echogenic bowel is the one where I end up spending most on my amniocentesis because the patient has to go through my entire CMV and rubella profile, and the fetus has to go through a lot of the cystic fibrosis testing, and of course my QFPCR and the exome sequencing. So echogenic bowel is always tricky, ascites is always tricky, and they both have the same manifestations. But I offer it to each one of them.
Yeah, that should be the most prudent course of action in such cases. Then there's one question for Dr. Pooja. Is there a different cutoff, femur length foot ratio cutoff for Indian population, or should we use a different cutoff for Indian population? This is a question which is, very, very important in Indian context.
So far, I'm not aware of it. The only thing when I went to the text and literature is that the femur length to foot length ratio below 0.87 is found to be significant in uh, guessing the possibility of skeletal abnormality. But I think my seniors would can enlighten me if they have come across some data that might suggest that. But I do not have the information about the Indian population for now.
Well, I don't use foot length and femur length ratio because precisely of the same reason. Because in Indian population, the femur can be very short and the foot can be little bigger in size, and it makes absolute mess of things. Varun, would you offer any your expert opinion on this, Dr. Santosh?
Sir, generally, I personally don't go by an isolated thing like the femur foot ratio. If I
Yeah.
have to take it into context, then I would look at other things also, like the other limb measurements, the height of the parents. If the previous scan was done, how is the interval growth of the long bones? At times, the long bones may be on the lower or even less than 5 percentile. But if, say, 2 weeks down the line, if they are growing appropriately, then more often than not, a skeletal dysplasia is ruled out. And skeletal dysplasias, I mean, they are not so very common that we get to see them every single day. So even prevalence wise, uh, we will not get to see them so often.
Yeah, likewise, same.
Yeah, so basically this question always stumps us. If the bones are short, is it constitutional? Is it due to FGR? Is it due to skeletal dysplasia? And yes, a single numerical value, I don't think that adds much to it. We have to look at various parameters and then come to a conclusion. And yes, we should offer genetic testing in these cases, and especially when we know that early onset FGR, it is associated with genetic abnormalities in 5 to 10% of the cases.
What I've also started offering now to all these patients who get worried about skeletal dysplasias is I tell them, look, the common ones do have these two genetic deletions, which is the FG, well, not deletion, mutations, the FGFR2 and the FGFR3. And if you want, we can run an NIPT for you. And so when you come back 2 weeks later for rechecking the measurements, my NIPT reports will also be almost ready. So why not? It is a little expensive, but it's available. And I always offer it. Looking at the cost, most of them say no, but then the onus is no longer on me, it is on them. So, and it helps them to weigh that, look, I refuse the test and therefore I better wait patiently, and they won't call you 25 times.
Yeah, so the
Yeah.
upshot here is that you offer the patient all the choices which are available today,
Yes.
and then the patient has to make up their mind which choices they want to pursue.
Yes.
Another question related to meconium peritonitis. Can there be a risk of sudden fetal demise in cases of intestinal obstruction or meconium peritonitis, Dr. Pooja? No, this is for Dr. Sonia.
Sir, actually, the risk is low, but it is said that if the massive fetal ascites, if it develops, can compress the lungs and can lead to a cardiorespiratory compromise in some cases, which could be responsible for. Also, if there is hydrops which develops in few cases, I had read a few case reports about this, and because of that, in our case, Mohit sir had decided that we should do paracentesis actually to relieve the pressure and allow the lungs to grow. Otherwise, the incidence of sudden fetal demise is relatively low.
Correct, because this is not the typical bacterial or
It is sterile. It is
it's a
sterile
sterile peritonitis. So it's not an infective
per
peritonitis,
se.
so
Yes.
per se. But yes, if a lot of collection develops, that can compromise
Yes.
and by compressing the other structures. So I think we have come to the end of the questions in the chat box. A few questions I have not covered because they were not related to the webinar's topics today. Any comments from the participants? Santosh sir, the closing remarks have to be from you.
I it's such a wonderful one of the participant just said it's fantastic that I joined the webinar because of such high level of discussions, and I always keep on telling my friends, they say I always every alternate sentence I say Corona sir said that, Corona sir said this, and SFM we do things this way, and so I'm so happy that the young generation is coming with such great ideas, and I'm happier that we are mentoring them in the right way. Unfortunately, when we were growing, we did not have so much of mentoring and easy access, but now that void has been filled, and I'm very happy that these young people are justifying the trust and the faith that we have showed into them. And I did not say it lightly when I said they can give an established fetal medicine specialist a run for their money. The way, the confidence, the knowledge, and the manner in which they were talking and the presentations was absolutely mind-boggling. And I'm very happy that the spirit of SFM, they have imbibed the spirit of the SFN, and I'm grateful to be a part of this fantastic association. So that's my really, I'm getting emotional because of this. I'm very happy that my Pune team is performing so well. And thanks, Alok sir. I said, Varun said, I fought with Alok sir that we want the webinar on the young because he knew we had the talent to make justice to this. So thanks a lot, sir.
Well, Varun, last time when you Pune chapter presented, and I think next month only he said, we want another chance. So I have to, hold him because other chapters also require a chance.
Yes, sir. So it took 15 months to get another opportunity, sir.
But we have 18 chapters, you saw.
Yeah.
So, yeah, so it's always a great pleasure to interact with the young guns, and every time we are interacting with them, you end up learning so much from them. So wonderful webinar, Kurana sir. Good night. Good night words from you.
This was excellent, and as someone mentioned a little while ago, just so Mohit had mentioned this, it's just so satisfying to see such excellence that seems to be growing in every single building that we have a member of Society of Field Medicine in. It's absolutely phenomenal. We never expected this when we founded the society in 2011, but really speaking, we are blessed in this nation to now have the right people to take care of the fetus in such large numbers and with such levels of excellence. Thank you to every single member for making this society such a success and for making our dreams come true in such a short time.
Wow.
Okay, so we come to an end of the webinar, and then next month we'll meet again with another chapter, other set of young guns, and new cases. Until then, goodbye. Good night,
Goodbye.
everyone.
Good night.
Bye.
Good night.
Bye.
Thank you so
Thank
much.
you.
Thanks.
Good night, sir. Bye
Thank
bye,
you,
everyone.
Thank you,
everybody.
everyone.
Thank you.
Bye.
Thank you.